Fred, I've written down some questions, but thank you. That that was a great talk. I've asked and seen a couple of people do it, and that's really as good as I've seen it. So, um, the question about the dosing strategy where you give your drugs Q6, um, has that really helped in cases where you've seen a tachypneiopathy? Does it make a difference? And then the second part to that is, how do you, and I say this because we've got some residents online who think digoxin is something that came from the dinosaur, is how do you treat your patients with digoxin? How do you load them orally, IV? In the patient with heart failure population. So case two, I'm referring to.
Okay, so I mean, the question of Q6 metoprolol is more of a practical titration strategy, and so it's really somebody shows up with a fast heart rate. The reality is they probably need metoprolol 50 or 75 twice a day, and you want to get there as fast as possible. But you're a bit gun shy to start right up at that dose, and certainly if they're in heart failure, you could exacerbate their heart failure if you put them on a high dose so acutely. So giving it every 6 hours, you get to give them a quarter of the dose at the time. And so you can start at 12 and a half, which is really 25 BID. And you can titrate every 6 hours as you're assessing the response to these sort of incremental increases in beta blocker. As for the second part of your question, the digoxin, I typically will give a zero point 0.5 milligram IV load, and then the second dose, I might give IV or oral, and I'll typically do 0.25 every 6 hours for two doses. And then the following day, they'll receive their renal adjusted dose based on their creatinine clearance. A lot of times, I may not necessarily send them home on DIG. I might just continue titrating the beta blocker and stop the DIG altogether before hospital discharge.
There's a comment from Paul McDonald who says he's used it even lower, a more frequent dosing strategy every couple of hours. So, Mo, do you want to address the issue about from Adam Clark there?
Yeah, so he said, thanks, helpful review. Are you using more digoxin now than a few years ago as only rate control agent? How often do you pace and Blair AV node, ablate AV node? I have found immensely helpful for selected patients, yet often have to refer multiple times to get this completed. So I'm assuming he's talking about the ablation that he has to do.
Yes. Yeah.
All right. So with regards to digoxin, I can't say that I use a whole lot of digoxin. It's a good add-on therapy, but on its own, I haven't had much success. The guidelines would say that it's a reasonable choice for sedentary patients. It's been shown to be relatively effective at controlling the resting heart rate, but not so effective at controlling an exercise heart rate. With regards to pace and ablate, we do pace and ablate fairly liberally here. I did have a 35-year-old with a lot of atrial fibrillation and atrial flutter, and because of his age, he really had to beg me to ablate his AV node at that young age. But generally speaking, if they're intolerant to medications, most patients feel a hell of a lot better after an AV node ablation. I kind of go off guidelines here, and I typically offer all these patients CRT pacemakers, as opposed for them to waiting on them to prove that they don't tolerate RV apical pacing. There's a lot of patients that, even though their EF remains normal, feel better with CRT compared to RV apical pacing, so they can actually feel the difference.
Next question from Ron Bourgeois in Moncton. Heart failure and AF heart rate control, other than targeting a rate less than 110, what percentage of tachycardia are you willing to accept on a Holter, 30 or 40? And I guess I'm going to put that a little further. Do you accept an average heart rate of less than 110 if it's 105 and heart failure or 100? Do you push it a little further?
In the context of heart failure, especially if there's reduced ejection fraction, so if the EF is less than 50%, I will want probably stricter heart rate targets. And so even 100 is probably too fast in a heart failure patient. And really, your ultimate long-term chronic goal is probably an average heart rate that's less than 90. With regards to the percentage of heart rate above 100, um, if you look at regular Holters in healthy people in sinus rhythm, they're over 100, anywhere between 10 and 30% of the time. So that's kind of the normal range for comparison. So 40% is getting higher than probably somebody in sinus rhythm, but in that scenario, I mainly focus on the average heart rate as opposed to the amount of time they spend over 100. And of course, I mainly look for symptoms.
Okay.
All right.
Oh,
The next question is from Iqbal Bada. Is your patient on long-term digoxin? What blood level do you keep them on at?
Limit the risk of toxicity. I try to keep their level less than 1. So I always tend to, um, if their renal clearance dictates, let's say 125 micrograms, I'll probably go 0.0625 instead. I usually go 1 notch less.
you made the reference to the FIN-CV study at the beginning, and quoted estimates of stroke in patients post cardioversion, and showed them from an observational study. And I'm going to turn this question around a little bit and ask you, have you seen a patient post cardioversion who's had an acute stroke, who had a perfectly normal heart and a CHAD score of 0?
Kind of thing.
Maybe ask the audience
Yeah.
if anyone has seen that patient.
I have not. Perhaps someone has, but
Yeah.
the risk with CHAD 0 is actually quite low, even within the first 48 hours. And in the FINCV, I think all those patients had a CHADS VASC greater than 2.
Yeah, I mean, I raised this as a question, and it's a big fight from the last set of guidelines, and there was a whole debate in the CJC about it, about why do we anticoagulate people, and it flips the question on its head, which is, if you see the person acutely, after you try and slow them down, decide what to do, is the next thing you should do is take out the echo probe and determine do they have a normal heart or not. And if they have no risks and a normal heart, might you be able to get away without something else? So I digress. I'm rambling as to personal anecdote and behavior. Iqbal asked the question, what do you call toxic levels? So what level do you call toxic for
Well,
digoxin?
it's not so much toxic levels as toxic symptoms. So I often see patients on chronic digoxin who develop anorexia, and you stop the digoxin and they start to gain weight and eat again. So anorexia and nausea are common chronic digoxin toxic symptoms. I see those a lot in the ICD clinic with my heart failure patients. And otherwise, there are the classic toxicity, bidirectional VT, heart block, but those are pretty extreme levels.
Okay. I've 2 questions right here. Just see if I can. First is, like, how do you decide if your patient would go directly to AV nodal junctional ablation versus just AFib ablation?
So the strategy is completely different. And so a patient in whom I offer pulmonary vein isolation for targeting atrial fibrillation is a patient that has a chance of seeing sinus rhythm again one day. So I typically want a patient that is able to maintain sinus rhythm after a cardioversion for some amount of time, that's not necessarily massively overweight, that has sleep apnea that's been addressed. So all the other risk factors for ongoing atrial fibrillation have to be addressed. And then I have to think that the symptoms he's having are related to being in atrial fibrillation versus sinus rhythm, as opposed to simply a heart rate problem. If it's simply a heart rate problem, then pulmonary vein isolation is a very expensive and difficult way to get the heart rate down to where you need it.
So the other question I have, if we have time, is I've talked to you about a few cases that had in CCU on call, that they come in with atrial fibrillation, rapid ventricular response, and we put them in IV amio, and they tank. They they become hypotensive, unwell, some of them crash, you might need to give them some pressors. Can you shed some light on that?
Yeah, so I mean, IV amiodarone is a poison. The diluent in IV amiodarone is polysorbate 80, which is a substance that causes vasodilatation and is a negative inotrope. So the hypotension you get from IV amiodarone can easily be avoided by giving oral amiodarone instead. So typically I'll give 400 POQ6 for 48 hours. If you go past 48 hours with high dose oral amio, you'll get extrapyramidal symptoms. So then after that, I drop to 3 times a day. And using rapid oral loading will get rate control almost as fast as using IV amio without any of the hypotension. The only time that doesn't work is with severe anasarca because they don't absorb the drug.
All right, thank you very much.
There's a question here from Fruze. Digoxin for atrial fibrillation in hemodialysis patients, always a no? Question mark.
You can use the lowest dose, and you just have to monitor for symptoms of digoxin toxicity. I mean, it's not necessarily my first go-to choice, but you can use low-dose dig, and surprisingly, you still have to dig load them, even though they're dialysis patients, if you're looking for a rapid onset of action.
Dr. Bada has dialysis patients on digoxin. I'm going to make a comment about Dr. Bada having all his patients on digoxin. I'm just kidding.
It's like we have Dr. McCallum here. He likes all the digoxins.
I'm not as much as enamored as Dr. Bada, but more so than the mainstream at the present time. I find it very useful. Your approach, Fred, in terms of managing the person with a tachymyopathy or LV dysfunction and atrial fibrillation, like I really like it, and I think it's something where I've frequently seen harm, and we are the cause of the harm with aggressive loads of drugs that cause people to get sick, and I've seen patients on a balloon pump on 3 pressors who walked into the hospital with atrial fibrillation at 165 beats a minute. You know, aggressively treated in the emergency room. We got them just in time. No, we just just about killed them with IV cardizem and an EF of 10%. Yeah. So, Dr. El-Khatib, when do you want to see those patients after first failed rate control medication or after antiarrhythmic failure? So I guess this comes to you as an electrophysiologist. When do you want to see these patients?
I mean, I don't mind seeing anybody anytime, really. I'm not too picky, but a consult is a consult. If you're having trouble managing a patient, I'll gladly see them and help you out. I mean, if what you're looking for is help in rate control, and you've tried drugs at a high dose and it's not working, it seems very reasonable to send them to me to consider alternative, more advanced therapies. And the same with antiarrhythmics. I think they're probably best managed in the hands of an electrophysiologist. You can start them, but then what happens after is probably best managed by electrophysiology.
Something you hadn't mentioned that is anecdote that I've been told, and I think I've seen, is the role of Nadolol as a more potent rate controlling drug. Do you have any experience, any comments?
Yeah, I mean, I did get that in my teaching as a cardio resident, and
Okay.
I haven't found it to be this wonderful, magical drug as a non-selective beta blocker. It probably works better for VT Storm, but I'm not sure it makes any difference in the context of rate control of atrial fibrillation. I suspect it'll make the patients feel worse.
Okay. Maybe if they feel worse and they're sitting down, they're complaining less of their palpitations. So that's it. Yeah. I think I've seen some anecdote where we've taken people off high dose conventional beta blocker, and maybe it's the metoprolol switch and the ultra metabolite.
Yeah, Nadolol. I'm trying to remember the pathway for Nadolol. It's not CYP2D6 or it's various pathways as in multiple metabolites of the drug, if I recall.
Okay. Dr. Bourgeois says he's had an N of 2. Atrial flutter seemed to have some benefits versus metoprolol. Okay. I think, Fred, we're at time. Mo, do you have any other further comments?
Oh, thank you very much. Just Dr. Bakhtir Kidway has his hand raised. I mean, if you have a question, I'd be more than happy to answer it on the panel chat.
Okay, yeah, so that's how we're dealing with questions back here. If you can write it. We've got some ongoing Nadolol teaching, and apparently it's renally excreted from Howard. AJ, knowledge of fountain of all knowledge says it's renal accumulation, so we'll see. Again, thank you very much, Fred. Very practical, touched on some important issues. You know, I think to come back to the AV node ablation, we're a very conservative center in terms of doing that, but we had a former member previously who's been in Victoria who was a proponent, Larry Stearns, and really described anecdotally, just as you said, in highly selected patients benefit. So